New York's classic rock, Q1043.
I say good morning a second time to Dr. Richard Wahl. He's president of the Society of Nuclear Medicine and Molecular Imaging, and he practices at with the Washington University School of Medicine, the Institute of Radiology in St. Louis. Now, when we Dr. Wahl, we talked about nuclear medicine, diagnostic scans, helping diagnose different types of cancer. And we talk specifically about pancreatic cancer. Today, we're going to talk about nuclear medicine helping detect other diseases, Alzheimer's disease, Parkinson's disease, stroke, epilepsy, brain disorders, cardiac issues. Dr. Wahl, is nuclear medicine well known as a diagnostic tool for all of these ailments?
Well, Shelley, again, it's good to be with you again. And I would say nuclear medicine is well known among professionals in healthcare. At least many professionals are aware of it. But I think many patients are unaware of how important nuclear medicine is and how versatile nuclear medicine techniques are for diagnosing precisely a whole variety of diseases, not just cancer.
Is it available everywhere or just some places?
I would say that most hospitals with 75 to 100 beds or more would have nuclear medicine techniques. So the technology is widely available. The PET-CT technology and some of the nuclear medicine techniques are also available in outpatient imaging centers in some locations. So I think one of the challenges with nuclear medicine is it's a little less available in rural settings. So access sometimes can be more challenging in a less populated part of the country. Certainly not an issue in New York City. You've got nuclear medicine facilities all over the metro area.
Is it also used, is nuclear medicine also used to treat illnesses?
Yes, absolutely. And that's a big part of nuclear medicine. I mean, the diagnostic part can precisely tell you if somebody has disease, where it is. But the therapeutic part for some diseases is growing and growing in application. And they're, not to be too technical, but we give a higher dose of radioactivity to a patient that specifically targets to tumors. And we're then able to treat the tumor with the targeted radioactivity. Some of the areas of interest that we discussed in the past were pancreatic tumors, such as neuroendocrine tumors, which are kind of rare, but where the disease really works well, but where the therapy really works well in the disease. Other ones include thyroid cancer, lymphoma, and I think a lot of excitement right now in the treatment of prostate cancer, both bone disease that spread to the bone and disease that spreads systemically. There's great progress in this space and a tremendous amount of interest in the therapeutic applications in nuclear medicine.
Is this the same as Cyberknife? When people say Cyberknife surgery is nuclear medicine, is this just the same thing?
No, the Cyberknife, the radiation source is outside the patient, so it's an X-ray being shot into a patient. The nuclear medicine techniques are the radioactivity for therapies injected into the patient, and then it homes to the sites of disease. So if the disease is in 15 places, the radioactivity will home to that tumor site, to those tumor sites. So it's an internal form of delivering radiation.
And what are the side effects, for example, treating nuclear medicine for prostate cancer?
Well, again, the prostate cancer is one of the agents, is several agents that are approved, and there's another one that's close, I think, to approval. And basically, the side effects can include some fatigue, some decline in blood counts transiently. One of the agents that's not yet approved tends to make some patients have a dry mouth for a while. Those would be some of the more common ones. It's actually, in general, when it's examined compared to chemotherapy, much better tolerated than more traditional cancer therapies because it really is targeted. So one of the attractive things about nuclear medicine therapies is the side effect profiles are really quite good.
Is this used in lieu of surgery or with surgery?
Well, Shelley, I guess if there is disease that's just very localized to one spot, very commonly surgery is the best way to deal with localized a single tumor, to have it removed. If you can remove it fully, that's great. These therapies are really more appropriate for disease that has spread to multiple spots where there's no possibility of taking out all of the different areas. Yeah, what we call disseminated disease, this is where we typically would apply the nuclear medicine therapies. And unfortunately, patients, that's actually what patients will die from, is disseminated cancer as opposed to cancer in one spot in general. That's the difference.
So if somebody is diagnosed with prostate cancer, can they be assured that their urologist will know of this alternative treatment if it has spread?
Well, again, I think we're still in an educational phase, and participating in conversations like the one we're having today is helpful to make the public aware of this technology. But I think the urologists are increasingly aware of the availability of what we call radiopharmaceutical therapy, the nuclear medicine therapies, as one of several possible approaches to treat disease. Again, when the new therapy that's targeting the PSMA is approved, which we hope will be this year, I think there'll be even more interest in using this therapy in patients in whom standard therapies have not been successful in controlling the disease.
So again, I'm thinking of, my audience is predominantly male, and
Sure.
prostate cancer is certainly a very common cancer. And so who should they contact if they've been diagnosed, it's spread? How can they find out if they can get this treatment? Where did they begin with this?
Yeah, I'd say it's a two-stage process. So for instance, if a patient has had treatment for prostate cancer, sometimes the prostate cancer is treated with surgical excision, what they call a prostatectomy. Sometimes it's treated with external beam radiation, let's say a Cyberknife, or what they call IMRT, but an X-ray therapy, radiation therapy. Those patients, some of them will recur, and those recurrences are shown by a blood test called the PSA. So if that PSA is rising, then the question is, where is it coming from? Is it coming from where the disease had been, the local site, or is it from disease that is more widely spread? What we didn't talk about, we might have talked about it last time we spoke, but just to refresh, there is a scan that's FDA approved, actually a couple of them now, that can be used to identify where prostate cancer is located. It's called a PSMA targeted PET CT scan. So the PET CT scanner is the scanner, and the radioactive isotope that's injected goes to the prostate cancer that expresses this marker called PSMA. So the first thing that would be in that rising PSA setting would be to inquire to their urologist or to their medical oncologist, where's this coming from? Do I need a PSMA PET scan? That's where you would start. If the PSMA PET scan were positive for disease in the bone, there are therapies right now for that. If it were positive for disease in soft tissue that elsewhere in the body in multiple spots, the patients would then potentially be candidates for this newer therapy. Again, I caution that the therapy is not yet FDA approved, but the pivotal trials have been done, and we're very optimistic we'll be seeing this available because it's available widely in other countries right now. So that would be where you'd start. You need the scan to say, okay, here's tumor, here's where it is, it's got the right marker, and then I'm going to use a therapy that targets that very marker in this specific patient. So you're informed by the diagnostic agent, if you can get it. And that's something we're going to discuss, I think, a little bit about access to these really important diagnostic agents.
I'm speaking with Dr. Richard Wahl, president of the Society of Nuclear Medicine and Molecular Imaging. He practices at Washington University School of Medicine, the Mallinckrodt Institute of Radiology in St. Louis. When people hear nuclear medicine, it sounds scary, and they think, I don't want to be nuked. That's not safe.
Well, I mean, the name nuclear does at first glance sound scary.
Yeah.
But it was put in place a long time ago. Some people call it molecular imaging instead of nuclear medicine. If you say molecular imaging, that probably sounds less scary. But the fact of the matter is nuclear medicine diagnostic studies are very safe. Patients are injected with a small amount of radioactivity, a very small amount, what we call a tracer amount that goes in, lets us look at the disease, cancer or some of these other diseases, and then it decays away. And after you get your scan and you're done. So it's a very low radiation dose for these diagnostic procedures. But, in terms of names, nuclear medicine can be, we have to realize that it's a valuable diagnostic technique that's safe. And on the therapy, we want to give a higher dose so that we give enough to kill tumor cells. So, but even then, the side effects are much less in general than conventional, say chemotherapy that kind of targets everything.
And another big issue is nuclear medicine as a diagnostic tool and or treatment. Is it covered by most insurance companies? Is it covered by Medicare?
Well, and that's a very good question. And this is one of the challenges. The nuclear medicine diagnostics are really revolutionary, but there's some peculiarities in the Medicare rules where let's say the cancer imaging agents, for starters, like the one I was discussing. In 2008, Medicare decided to bundle or package payment for diagnostic radiopharmaceuticals into payment for the imaging test. So basically, what happens is Medicare will pay for some of these innovative scans, but it pays for the drug, the innovative radiopharmaceutical as a supply. So it under reimburses hospitals to do the scan. So it doesn't pay for the cost of the scan. So this can be a barrier to access for patients. It's a little convoluted, but there's a period of time of about 3 years where Medicare does pay. And then after about 3 years after the drug is introduced, then they pay what's called this bundled rate. And what that means is the hospital would lose money on every case because they don't get reimbursed as much as
Right.
as the imaging drug. So this can be a barrier to access, as some hospitals, in other words, you can't make up in volume when you're losing money on every case. So this is one of the concerns that the society and a broad coalition of patient advocacy groups and professional societies are trying to address through some legislative action. It's called the FIND Act. So we're working with Medicare trying to get this through, but we believe it needs to be done legislatively because Medicare can't do it on their own. So the FIND Act is designed to. We can talk about it more, but it is really and there's information. I guess I can say that your listeners can go to the Society of Nuclear Medicine website, the snmi.org, and on the front of that page, there's a lot of information about the FIND Act, which is facilitating innovative nuclear diagnostics. And basically, this would make these innovative radioactive diagnostics available to Medicare beneficiaries, because it doesn't do any good to have the drugs, but only have them available to people who can afford to pay for it. It results in a significant health equity issue. And we know, as for prostate cancer, as an example, that it disproportionately affects the African-American population. So this is, I view, as an equity and access issue. So this is under consideration. We've had it. We have several legislative sponsors, multiple, and certainly we would hope that your listeners would be interested in supporting this, because it doesn't do a lot of good to have the science and have the technology and then not have it accessible to the patients who can benefit.
Exactly. If they want more information, again, where do they go?
snmmi.org, Society of Nuclear Medicine and Molecular Imaging.org, snmmi.org.
Okay, thank you so much, Dr. Richard Wahl. I'm sure we'll have you back with more as things continue to develop in the industry. And I'll see you guys tomorrow morning on the Jim Kerr Rock and Roll Morning Show, Q104.3.
New York's classic rock, Q1043.